Assalamu alaikum wa rahmatullahi wa barakatuh. Good morning, my colleagues. On behalf of the pediatric department in Imam Sadiq Hospital, we are welcoming our guest. Special welcome to Professor Dr. Lamia Saadi, Dr. Hakim, and to all my colleagues. We held this committee by our committee, Dr. Ayad and Dr. Ihab, Dr. Ammar Saeed, and this is our 7th international webinar. Special thanks to Dr. Nicholas Embleton who make this happen and help us through all this year. Special welcome to Dr. Ahmed Shimran, Dr. Muhannad from our Pediatric and Maternity Hospital in Babylon. Also, a special welcome to our colleagues and trainees and our doctors from Iraq, from Sudan and Palestine will join us after a few minutes, I hope. And also, I will go to my colleague, Dr. Ammar, to introduce our international speaker, Dr. Naveen.
Assalamu alaikum wa rahmatullahi wa barakatuh. And good morning to our esteemed guests. It's a great honor to welcome you in this scientific international webinar, a collaborative effort between Imam Sadiq Hospital, Babylon, and the Royal Victoria Infirmary, Newcastle upon Tyne. In this webinar, we shall focus on three important topics: the golden hour of neonatal care. We are pleased to welcome our international guest, Dr. Naveen Kumar Atherman, a consultant in neonatology at the Royal Victoria Infirmary Hospital, Newcastle. Dr. Atherman holds MRCPCH qualification from the Royal College of Pediatric and Child Health and MD from the University of Manchester. Over the past 2 decades, he has conducted extensive research on complex topics of pediatric and neonatology. Notably, he led a groundbreaking study founded by the NHS England in collaboration with Genomic England. This study facilitated the testing of a newborn over 200 rare genetic conditions using a blood sample obtained from the umbilical cord shortly after birth. What about the golden hour of neonatal care? The golden hour is the critical first 60 minutes of the newborn life, especially for vulnerable and preterm infants. This period is vital for stabilizing the baby and to transition from the womb to the neonatal life. The main focus area include thermoregulation, respiratory support, glycemic control, delayed cord clamping, and skin-to-skin contact. The concept borrowed from the adult trauma care. He was adopted to neonatology to standardize and optimize the delivery room management. It emphasized team coordination, checklist, and timely intervention. Implementing golden hour protocol significantly reduced complications like hypothermia and hypoglycemia. In the preterm infant, study shows marked reduction in serious comorbidity, including intraventricular hemorrhage and bronchopulmonary dysplasia. So we are excited to learn together. Welcome all. Now we shall leave the air to Dr. Ihab, consultant pediatrician, to start the webinar.
Thank you, Dr. Ammar. Thank you, Dr. Lubna. Professor Dr. Lamia Saadi, Professor Ahmed Shimran, my colleague and friend Dr. Hakim Youssef, my friend Dr. Muhannad, all colleagues and pediatric trainees, welcome to this webinar. Before we start the webinar, we have a record of Dr. Embleton, who hosted the 3 previous webinars. He's now in Palestine doing a workshop on neonatal transport in Al Khalil.
Dear guests, fellow pediatricians, nurses, and other healthcare workers from Iraq and any other countries that are joining the webinar today. I'd like to start by thanking EHAB for allowing me to share a few words and reflect on the series of webinars that we have shared, and also my own career as a neonatologist. My name is Professor Nick Embleton, and I've been a neonatologist in Newcastle in the UK for more than 30 years now. And I've had a wonderful career and have been busy reflecting on all of the things that I've achieved and all the challenges that I've faced. And as I say, being able to take part in webinars with colleagues from around the world, as EHAB has organised here, has been one of the highlights of my career. As many of you know, I've had an interest in neonatal research for many years, particularly in nutrition, but also in some of the challenging aspects of baby loss. I'd like to think I've really had a wonderful career, and recently I have spent a lot of time reflecting on the privileges that I've had in life, the privileges that come with having been born in a rich, stable country, the privilege of an academic career, and the ability to follow my interests, my love of neonatology. And over my career, I've seen many advances in neonatal medicine. And of all of these, nutrition really has emerged as an important specialty within neonatology. Now, although I can't join you for the webinars today, by chance I happen to find myself in Jerusalem, just 500 miles west of where you're sitting today in Babylon. And I've been here last week, and I'm here for one more week, working with Palestinian doctors, joining ward rounds in Jerusalem, but also in the West Bank, teaching and helping them establish a neonatal transport system across the West Bank. And I've been genuinely inspired by their resilience in the face of such daily hardships. But also I'm inspired by their thirst for knowledge and their kindness and generosity of spirit and the welcome that they have shown me. Now, my travels here have been somewhat challenging to reach here across the borders, given the current situation, but it's also given me some time to spend alone in the Holy Land. I've been able to visit the Old City in Jerusalem, the Western Wall, the Church of the Holy Sepulchre, and although I wasn't able to enter the Al-Aqsa Mosque or visit the Dome of the Rock, I was able to spend time with Muslim friends and feel the presence of the faith that you have. And today I went to the Garden of Gethsemane, and I reflected on the Abrahamic religions, what you share and how you are bonded through faith, even though you see some of the aspects differently. All of you fundamentally believe and have a faith in God. And this made me reflect on what joins us together in neonatal medicine and science. We see our challenges from different starting points, and maybe our practices differ. But like the three religions that are also bonded, we're bonded by our shared desires to learn together and to work together with a shared common goal to care for the most vulnerable members of our society. 2025 has, of course, been a very challenging year for many people in this part of the world, especially those living under occupation or war. And with you, I pray for a better future. I hope these webinars are but one small example of the power of being connected across the world. And very much one day, I hope I will be able to visit you in the cradle of civilization and learning in Babylon. So thank you very much, EHAB, for offering me this opportunity to say hello to everybody today. I hope you have a great day. I hope there are many learning opportunities. And I'd like to wish all of you happy Christmas and a happy new year for 2026. Thank you.
Thank you. Thanks very much, Dr. Syed, and thanks, Dr. EHAB, for inviting me. It's a pleasure to join. So this is a half an hour session on golden hour. So means the neonatal world, and in fact the adult world, has known the golden hour for a long period. So I think neonates introduced golden hour in 2009. So it derives from adult world, where the first 60 minutes of A&E or trauma care is absolutely essential for the best outcomes. It's similar to that, the neonatal derived that, and now there's more and more evidence to show that the first 60 minutes after birth of a newborn life is essential for multiple aspects of their short and long-term outcomes. So we'll have a quick chat about it, and it's also to talk about our experiences primarily, because we've known about golden hour, we've discussed about golden hour in our unit for multiple years, and then eventually we started having a QI project and implemented it. So I'll just go through our experience and see, and then have a chat essentially. Right. Yes, that's the one. Yeah, so what is golden hour? So first 60 minutes of a newborn life is the golden hour. It's not the first 60 minutes because that's one of the common assumptions in our unit was when we set up timer, when the timer was set for 60 minutes after the baby came to the neonatal unit, but it's actually the 60 minutes from birth. So it's quite important to differentiate that. And potentially the most active part of the management because in sick newborns or preterm newborns, it's one of the highest number of procedures or highest number of activities in sort of management for a baby, and so it's quite important time for the little one, and it actually captures both delivery room and the NICU. First slide is essentially about what golden hour means. We've it's the first 60 minutes of newborn life, and actually it includes both delivery room and the NICU care. So it doesn't start from the time when the baby comes to the NICU, and it's quite important to recognize the difference. And it's also the most important part, one of the times when we do most management aspects for a baby who's sick or premature, actually. Next slide, please. Yeah, so this is an article for Deepak Sharma, which is essentially says the same. So this is if you look at a term newborn, so the most common or one of the biggest reason for mortality is asphyxia, HIE, which we know that if you can actually prioritize and do an effective resuscitation, the damage can be minimized. And so, and that is one of the important things. So time is essential in this situation. And in golden hour approach, the importance is given multiple aspects. One is evidence-based resuscitation, and then comes post-resuscitation care. There are a few other things which we focus on. One is delayed cord clamping, and prevention of hypothermia and hypoglycemia, early breastfeeding, not necessarily in HIE babies, but in general. In the first hour, we focus keeping them normothermic and feed them early, reduce the chances of them going hypoglycemic, and in case of HIE, start treatment, mainly cooling therapy, as soon as we can. And so all of that is focused within 60 minutes of life. And in HIE, obviously, we do a bit more than just cooling, but we'll yeah, so we can discuss that later on. Next slide, please.
Next slide.
Yeah, so this is what we used to have. So this is the guidance we had for years. So I've been working in RVI for almost 13 years, and so we've had this first 24 hours NICU care pathway, which also includes the first 60 minutes, the golden hour. So which is the next slide. So you can say essentially. So in the 24 hours, it not just captures what we do for the first 60 minutes, but then talks about what are the important aspects of care going forward. But the most important part is do everything as soon as you can and leave the baby alone. We know that gives the best outcomes for sick kids and for premature babies. So we know that babies with, for example, term babies, meconium aspiration or pulmonary hypertension or severe sepsis, and all of them who need significantly high support early on. So the main idea is to do all you have to do, including lines, antibiotics, fluids, and then get out and leave them alone. That's essentially what we used to practice. But then, because we didn't have strict criteria, we never adhere to the 60-minute golden hour protocol. So this is where we did an audit before, and then we'll discuss that later. And then we started a QI project to help us adhere to this golden hour strictly, and also have pathways and processes in place to support this, which we'll have a chat. Next slide, please. Yeah, so this is our original guidance, which talks about the first hour. You can see there's multiple steps it discusses, which are essential for the first hour. But I think for the team who are extremely busy that's what we recognize, who are extremely busy and stressed in the early hour, 2 hours of admission. They need clear guidance and clear pathways to actually make sure that things are achieved as we plan. And so having this guidance was quite important. People recognize the importance of golden hour, but never followed it. That's the gist of it. Next slide, please. And so when we thought about setting a golden hour project, a QI project, and then we started thinking about what are the most important things and looking at the evidence as well. There's plenty of evidence online. And obviously Google Gemini gives you everything you need, but actually we started to look for what is relevant for us. Every unit has their own things which we focus on. So we then looked at what are the things we need to focus on. So these are the 5 things. One is establishing respiratory support, which includes delivery room care plus once the baby is in NICU, the aim is to connect to a ventilator as soon as we arrive, and so early respiratory support and keeping a very close eye on hypothermia. So we introduced rectal probes from birth, which means we can monitor temperature all through resuscitation and along the way across to the neonatal unit, and then continue monitoring it. Focus on drips, IV fluids, IV access fluids and drugs, and then investigations. Essentially, most investigations are done while we do the IV access anyway, and also not to forget about the family integrated care and colostrum. We have a colostrum pack, so we try and meet parents within 60 minutes. We usually meet in the delivery room just after resuscitation if mom and dad are around. But I mean, if mom is awake, and we try and even hand the baby across for a skin to skin for a short period, like 30 seconds, 60 seconds before we come to the neonatal unit. And then we give a colostrum pack. So when we go back after early management of a baby, just to go give an update and give a colostrum pack so they can actually start thinking about expressing and as soon as they feel well. Actually, it's all of that was focused on. And the other thing you have to remember, as we were practicing this, we recognized one thing we are very good at is when we are task focused, we are brilliant at it, but we can be too focused and forget about aspects which are relevant around it, and it's important. That is one of the key learning points for us. Safety is a priority, so always remember ABC. Make sure that when you're doing all the lines and all the stuff which are absolutely essential within 60 minutes, that the baby is saturating well. So and we're not just completely ignoring that and focusing on our tasks. So it's quite important. Yeah. So why do you need to discuss this, and why does it really matter? The 60 minutes is a question we all know, but actually this is essentially the reasons. One is you want a consistent practice. So you want a standardized approach to all of the sick kids and premature babies. So any baby coming into a neonatal unit, you want the same approach, even if they just come for sepsis. So there are babies who come from postnatal wards at birth because they're risk factors for sepsis. So it's still the same practice we try because they come in and they get the cannulas done. We want to give the antibiotics within 60 minutes and send them back to parents and have a conversation with parents and focus on breastfeeding and hypoglycemia prevention, all sorts of things. So it's in a baby who's completely well, only risk factors of sepsis, we still try and follow that. But of course, any baby who gets admitted, it becomes a bit more higher significance for us. And so this is the primary things. So we focus then on hypothermia, so keeping the baby normothermic, infection treatment, hypoglycemic avoidance, and also and bonding. So these are the things. And so the evidence, there is also evidence that it has a huge impact on the long-term outcomes, including PPD, IVH, and ROP. So that is one review article I've included. So you can have a look. Next slide, please. Yeah, so that's so this is two articles I thought which are relevant. One of them focuses. It's a QI project, so which is why I included this. And does it make a difference? QI project, but clearly QI project when this project actually looked at all babies less than 34 weeks. And the golden hour care. So they had a strict criteria, and they developed a project and had strict pathways and criteria, and they showed clearly that reduced admission hypothermia, hypoglycemia, and also improved the time of admission to NICU and admission administration of fluids, PN, and antibiotics. So it made a huge difference. So I believe it did for us as well, so which we'll discuss in a minute. And the other review article, this is quite an interesting article. So by Michelle Amari, says looks at the current best practices and all the available evidence, and if you look at it, so the article says the implementation leads to improved short and long-term outcomes, particularly in very small babies and extremely premature babies. The short-term outcomes reported were hypothermia, hypoglycemia, establishing early IV access, timely initiation of fluids and medications, and long-term outcomes are BPD, IVH, and ROP. So you can see these are probably some of the things we constantly fight in the neonatal unit to get better at, and just by practicing golden hour strictly and coming out of minimal handling, essentially one of the big part for me as a neonatologist. The most important thing I want to do is leave the baby alone as soon as I can and as long as I can. I don't go in and examine every day unless I absolutely have to. I don't go in and disturb the baby every day, because it's quite important for them to have that time on their own to recover, and nursing team are excellent at picking up things which they're not happy about, and then we go and intervene only if we have to. And the golden hour is a good example for that, actually. So this is something we presented to our team. So we asked our team, can you describe any examples where we already practice golden hour and we think that we are doing quite well? And we had some interesting answers. But do you guys already practice golden hour, and do you have any interesting thoughts about it, or any thoughts about it, and things which goes really well in a unit for when it comes to golden hour?
Amar, I think you're the best person to answer this question.
Okay, Dr. Naveen. We have implemented early resuscitation to all neonate, prevention of hypothermia, but still we are progressing to more care. We need truly to implement the early institution of respiratory support, CPAP, and surfactant therapy as early as possible. What's your implementation about this topic?
Yeah, absolutely. I think so. I'll come through to that all aspects actually in a minute. So these are the things we focused on as well, actually. So we thought about all these things because we do have a standardized practice, and the one thing we are animals of. We're essentially we just historical practices. We just follow what we've done for years, and to change that, it takes a lot of breaking, and so the steps are quite arduous sometimes, but it actually works if you can do it. And I'll go through even the respiratory support, how we managed it. And yeah, so the big question we asked ourselves is how do we implement this practice at our NICU? Because a significant part of our team felt we already do golden hour quite well. And so this is the difficulty. So when we feel that we are so good at it, why change is a question people ask. And it's difficult to know unless you have evidence that we are not good at it, people won't change. That's the first thing. It's quite important to recognize it. And then so we had to produce that evidence and then have strict guidance to change. So next slide, please. So what do you need to change? So I'll go through some of the tools which we used, but the most important thing is lots of education, and you need teams involved across the board. So you want midwives to be aware and educated on that side of it, because you want them to and obstetricians, anesthetists, because we started having briefings. So if you have a known delivery. Of course, emergencies you can't plan, but majority of the babies preterm and fetal med, because it's a big quaternary unit, so we have a significant number of our babies are we already know about them antenatally because of the complex nature of these babies. So we have essentially what we call as a briefing, a team briefing, so which involves neonates, obstetricians, if it's theatre, if the baby is going to go if mom's going to have cesarean section, theatre team, anesthetists and ODAs and ODPs and all sorts of people. So it only takes 5, maximum 10 minutes. But everyone understands the roles and they clearly tell us what is important from their perspective. And for us, because so you probably recognize northeast of England is extremely cold. At this time, I'm standing in my conservatory, it's freezing. So it's in a unit, it's the same. On paper, it says 16 to 18 degrees, but when you walk into a theater or a delivery room, it is very cold. So babies here get cold very quickly. So we just need to remind them, because mums are very hot, so they want the room cold. Midwives are hot because they've been screaming as well, along with mums, and it's they want the room cold. But actually, from when a baby's perspective, you want the other way around. So we always have this fight. But actually, more and more they've recognized, at least in theatre, it's easy for us to turn the temperature up. So when we have this briefing, we clearly talk about environment, and so essentially keeping the room warm, increasing the temperature up, and that is also part of the discussion. So you want every team involved, neonatal team, midwife, obstetricians, and anesthetists if in case of cesarean sections, and everyone, so that we are all working together to get the times right. And from the time the baby is born, DCC is done, everything is done timely and safely. But that's the most important thing. What you don't want is lose that safety aspect of it. So we want to do it safely, but equally you want to do it in a timely manner, so you don't waste even seconds. Every second matters eventually. And we felt and it was useful to have a nursing lead, because we had a medical lead. I was very interested in this, so I led this QI project. We had Dr. Jalone, who's our colleague neonatologist, who's our simulation lead. So she did most of our, and you probably know Bara Hassan, was our sim fellow, who actually was the biggest motivator behind this, and then who led this through the time he was here as a sim fellow for a year, and that has helped us. That momentum kept going because of him. And so if you have a nursing lead and that momentum keeps going, and you have nurses taking over the ownership and initiative, because at 4 a.m. you can't have doctors pushing and reminding people. And
Dr. Naveen, for audience here, what is a sim fellow? What is the meaning of sim fellow?
Simulation fellow. So it's Bara was our simulation fellow. So so he did 1 year. So he's our neonatal.
Bara, you mean Bara, the Iraqi doctor who is training?
That's right.
Yes.
Yeah, in UK. So the same doctor. He was our simulation fellow. So he's a neonatal grid trainee. So essentially, he specializes. His training is his specialty is neonates, but he took time out of the training program to spend 1 year with us as a simulation fellow. So his primary focus during that 12 months is simulation, establishing simulation in the unit and across the region, essentially Northeast region. And he had few projects he wanted to implement along with Dr. Jalone. And one of the project I wanted him to take on was this QI project on a golden hour, because it's essential that you have a good team, and we felt that simulation would play a major part, and it did. And so Bara's role was and Jenna's role with Dr. Jalone's role was massive in this. And then awareness. So you want everyone to be aware that we're starting this and what it means, and what are the key things we are focusing in the first 60 minutes. So we had lots of educational resources displayed. And we have got educational board in the neonatal unit where there's a coffee room. So where people standing and drinking coffee or having a cake, you can read. So it's and then we had lots of simulation. Doing a simulation of golden hour is very difficult because that 60 minutes, everyone will lose interest. So we focused on short scenarios, essentially focused on the delivery room care, where the focus is doing things in a very structured way. So and then so that is like 10-15 minutes simulation. We discussed on admission of the neonatal admission on the neonatal unit. That's another very complex time where everyone is interested in their own things, and when it's done well and works, the time actually we do quite well when nursing team and medical team work quite together, and so those things needed practicing, and so it was all simulation. And so we included even midwives in simulation so that they understand their role at the time of birth and before birth. And then there was continual learning, lots of learning. And when we did audits, we started with monthly audits, which we'll discuss, and then gradually now we're trying to move towards 3 monthly audits, because monthly audits you need a lot of motivation for it, and you need personnel for it mainly. And yeah, so yeah, next slide, please. So once we decided, and this is what it is, we've done all the preparation, and we also wanted to know if there are tools we can use to help us remind, help us focus. And this was one of the things we thought about, golden hour pause. We prepared this. So there are aspects which in the next few slides we'll go through. So one is the team, environment, NICU, and on individual roles. So we looked at every aspect, and this is some felt we already do this anyway. Why do we spend another 5-10 minutes looking through this and preparing? Might be right, but for most, particularly for junior doctors, it gave them focus, and it gave them a clear idea of what they are going to do in the next hour, who does what, and also for nursing team, for them to prepare when the team is out for resuscitation or stabilization of the baby, that they knew what they have to start getting the incubator warmed up, and making sure the ventilator is on and connected, and making sure if there is a doctor, set the early settings, because we still need the weight for that, but they do the early settings, calibrations. So when the baby comes in, as soon as we know the weight, the baby is connected to the ventilator, which takes like 30 seconds essentially, because the weight is in the scales for it. And then that's one of the first thing they do, and then they connect it to the ventilator straight away. So it's kind of having that kind of idea, and of course environment and all those things. It helps. I think it helps. But some felt we are just wasting time, but that's also feasible. So we still trialed it for juniors. It made a huge difference. For nursing team, it made a huge difference. So it's quite relevant to think about what is useful tool for individual unit. And if you're starting to plan then it's worth thinking what would be useful for you. Next slide, please. Yeah, so these are the things when you look
Dr.
at
Naveen, just to remind you that we have 12 minutes. Try to choose the most important, informative slides.
Yeah, okay, I'll go through these slides.
Yes.
Yeah, thanks, Dr. Syed. So this is essentially, these next four or five slides is focusing on individual aspects which we looked at the previous, like the pause. One is anticipating an admission. We've discussed that, and we've discussed what are the preparation and required. And next slide. And in the delivery room, so one of the things we've added is a ventilator on our resuscitator. So babies, as soon as they get intubated and have QRSF in rooms, in the delivery room, we connect them to ventilator and tidal volume ventilate. So it's essentially extremely been useful for us because we support the respiratory support quite early on, and also for kangaroo care, because baby is connected to a ventilator with the ET tube secure. So it's much more easier to give the baby across to mum for few seconds for skin to skin, and then in the delivery room or in theatre before we leave. So that's also been very helpful. Speak to Band 7 is our in-charge nurse. Our in-charge nurse does everything for us, and we introduced this clock. Yeah, next slide, please. So this clock was also another very important part of our golden hour. Because how do we know what is the golden hour? So we usually use this clock. So now we have plenty of them. It doesn't cost much. It's very cheap. And then we calculate the time of birth and essentially set the timer 60 minutes from time of birth when the baby comes to the neonatal unit, and then monitored across. So we try and do things very orderly within 60 minutes, essentially. Yeah, so it includes access and the other important thing. So if you don't get, so juniors usually try it, and so the problem with trying is sometimes it can go 30 minutes, 45 minutes, 1 hour, 2 hours, and that is one thing we recognized. And so there's a very clear, so escalate as soon as you can. So 15 minutes, 20 minutes max. Doesn't work, escalates. You want seeing someone else to come and try, or at least assist you. So that was another important step. Fluids and drugs. You guys know this. So we connect as soon as the UVC goes in. We give all the drugs now. And yeah, as soon as the cannula goes in, once it's secure, we give all the drugs. We don't. So the person who's scrubbed up for UV lines would have given it already. So that is another thing we've changed. So that's done, and IV fluids even. TPN is the one which can take longer because it needs to be a sterile preparation. But even then, most of the times now, over time, it's ready by the time lines are in and drugs are given. So the person who is doing all that, who's scrubbed up already, connects the TPN as well. So it's actually because of this project, a lot of things have changed, and we clearly know we can do really well if we focus. At investigations when we do cannulas or lines, we get it done. X-rays is another thing. So some places have radiology working with the team. So as soon as the lines are in, someone calls them and they're here when the team is still scrubbed up. They do an X-ray. Any changes can be done straight away. It doesn't always work because they can be busy and out of hours, particularly they're on their own. But if it works brilliantly. But it's still that is one thing we can improve. But yeah. Next one, please. Yeah, we ask them to examine straight away. And so it's a person who is doing the lines straight after the lines are done, or just before he starts cleansing for lines, we ask them to examine. So don't go back in for it, just examine and do all those things. Next slide, please. And yeah, 60 minutes parental update and colostrum pack, we've discussed that already. Next slide, please. Yeah, the swabs and stuff, which always delayed our important task. So we always focus now and not focus on this. yeah, but we still do it, MRSA swabs, but that is not the primary focus. We created this golden board, which where we record all the timings, and that on its own helps us motivate and helped us motivate actually. Yeah. Next slide, please. Next slide. So this is another adjunct. Chloe Rolls is one of our ANPs, prepared it. It's mainly to help us focus on what are the relevant things and important things, which I'll leave that to you guys when and you can go through that, which is again similar theme. So delivery room, what are the focused? You can see that the main thing is minimize hand ventilation, avoid hypothermia, prepare for transfer, including parental discussion, and at Ward 35, what you do when you admit, and fluids, drugs, and additional steps. All of that it focuses on.
Can I interrupt you, Dr. Naveen? I know you have done work on neonatal screening for 200 genetic diseases immediately after birth. Can this be optimized to go with the golden hour? How quickly are results obtained after taking the sample for these genetic diseases as part of the screening program?
So that is that's a research project. So essentially that's called a Generation UK study. So that's a national project, and I am part of Newcastle team. I'm the lead for the Newcastle team. So so that sample is taken mostly, or almost always, from the cord blood. So we don't disturb babies. So the cord blood's taken, midwives take it, and we send it away. It's a whole genome sequencing.
How quick are results obtained in your practice? How quick are the results obtained?
No.
General neonatal
So it takes up to 3 to 6 months.
6 months.
At this point, it's actually early stages. In America, they did what they call as Guardian study, and apparently now they can do whole genome sequencing within a day. That is the best in the entire universe. That's only in America you can do that. Outside America,
the conventional neonatal screening? What about the conventional neonatal screening? How quickly are the results obtained in the UK now?
So conventional neonatal screening, for example, we do common things. We do is full blood count, group and that Coombs, CRP, and blood culture. Blood culture takes 48 hours. Full blood count, CRP, group and save will be around within 60 minutes. We should get the results back. But that doesn't come within golden hours. So that's outside that. But the results are back pretty quickly. Next slide, please. Yeah, so this is our original audit. When we decided we're going to start this, when people felt that it was not needed, we did this initial audit to look at our own practice to see how good we are and where can we improve. So there are a few things we focused on because doing an overall audit it becomes very difficult. And so we only picked 20 babies, small babies, premature babies primarily, and small babies. And here you can look at the main thing you want to look at is the time to lines. You can see 4 minutes to almost 2 hours. And the mean and median is 40 minutes, which means by the time people come out doing the lines already, you're too late. And time to the last task, it's 2 hours to 31 hours. Means I hope that's not. Yeah, so sometimes 5 hours we're still in, and you can see how relaxed we were with times is the word to be gently say. And so we clearly recognized we wanted to change lots of things and delayed things like baby examination, x-rays, and there was lots of inconsistencies in practice. And we recognized even putting lines in, people go in and spend an hour without blinking and not recognizing that they've not got it in. They've ruined all the umbilical arteries and vein, and the person who comes next is going to spend another hour not knowing what to do with it. So those kind of simple things we recognized, but we were also doing a lot of things very well. That's the bottom line. And so we didn't want to change everything, but we just wanted to tweak a little bit. That's essentially what it is. Next slide, please. And yeah, so we've discussed this already. So once we recognized it, what did we do? We formed a golden hour team, and anyone who was interested, we were happy. We had medical, neonatal team members, and then we did lots of simulations, skills practice, departmental teaching, and multiple audits. And we introduced golden hour pause and golden boards, lots of things to help, which we have had a look at already. Next slide, please.
We have
And
2 minutes
we
left,
then
Dr.
audited monthly.
Samin.
Huh?
We have 2 minutes left.
Yeah. So I'm just going to speed up actually. So
Yeah.
we audited again, and we focused on the important. We also focused on HIE babies. Next slide, please. I'm just going to quickly go through so that the key points are important. And this is you can see the percentage of eligible admissions where audit was completed, because audit had to be completed prospectively. So you could see the first 3 months after starting, it was still not good, but then gradually we started improving. I suppose that's expected for any project which we start new, and we noticed that. Next slide, please. And yeah, next, keep going actually. So this is a number of babies for 64 babies, and we focused on looking at few things. IV fluids. So the previous slide, if that's okay, please.
Previous slide.
And one more slide before, or yeah, no, next slide. Yeah, so access, you can see when it comes to UVC and UAC, that's the dark blue line. We were, apart from the March, we were consistently very good, and we recognized we were clearly getting better at that. Once we have time set. Next line. Next slide, please.
Next one.
And yeah, next one. MRSA swabs in general, we were delayed because of MRSA swabs. That's what that mentioned. And next slide, please. It's again lines and commencing fluids. Was, as I said, we started commencing PN within as soon as we got the lines in, that improved. Sorry, IV fluids and PN. But you can see the January, February, March, the PN was quite delayed. It wasn't done. Like sometimes it was done at 61 minutes, 62 minutes, but we still didn't include in the audit. We were very, very strict. But overall, it improved the awareness, but we still had a long way to go. Yeah, so almost 50-50 fluids and PN were started and not started within an hour in that period. Next slide, please. Antibiotics, caffeine, we gave everything together. So the numbers will be quite similar to the previous one. Next slide, please. Vitamin K is part of it. Next slide, please. Yeah, parental update is one thing we wanted to improve on. We wanted 100%. Clearly, we weren't achieving that because we wanted to focus on speaking with them as soon as we can. But most of the times we were very good at it, because colostrum pack was part of that. So we gave a lot of importance to it. Next slide, please. Yeah, admission examination is another big fight. Clearly, January was a good month, but none of the other months were good. Next slide, please. And yeah, so normothermia, yeah, we were much better. We used to be 40%, 50%, 60%. Now we start at 70, 80, 90, which is already good. We still have a long way to go, but yeah, we've improved. X-rays is, yeah, like I said, it depends entirely on a different department. And yeah, so it's not always, you can see it's less light blue than any other slides. So which means we were failing all the time, but that's something we're talking to radiology to see if we can improve. Overall, again, there is some improvement, but not all of them. But there is definitely improvement in IV access, fluids running, temperature, parental updates, but there are lots of other things we need to work on. Yeah, next slide. So what does our data tell? We clearly can do very well as long as we are focused. MRSA swabs did interfere, and we tried to push it as last as possible within 60 minutes, and so it worked out well for us. Focus on areas of improvement, like making sure the TPN is run early parental update, admission examination, temperatures, and vitamin K. Based on our audit results, we focused more and more. Next slide, please. Yes. So so what can we do? Anticipate, work together as a team, have a very consistent approach, have used the tools which were available, and then we were pretty good at it. When we could do that and engage with learning processes. Next slide, please. Yeah, key takeaway points. It's only 2 slides left. And the key takeaway points for us, focusing on the key tasks should be the tasks which we discussed earlier on, the 5 key tasks, and then golden hour goals were quite important, but recognizing that don't be too task focused. Focus on the baby and make sure the safety is absolutely paramount, and urgent ABC priorities are relevant. And that is one of the big things when sometimes we were so focused, the baby was saturating 60s. The nurses were taking the golden board information, doctors were focused on doing things, we forgot the other aspects. So it needed that kind of learning for us. Patient care approach, and that's the main things, which is all good. Yes, I think I'm pretty sure the time's finished. So
thank you very
thanks
much
for listening to me.
for your presentation.
We
have professors here from Baghdad and from Babylon. Do you have any comments, professors?
The parental nutrition, is it used in the first 60 minutes of life of the newborn baby? Especially most of the babies are premature.
Yeah. We introduce PN on day 1. So we now start PN straight after getting the lines in. So most times we've got the PN on board as soon as the UVC is in and secured. So which is probably 30 minutes of life.
30 minutes of life.
But that needs a lot of work, because you want, when we get the lines in, so essentially what happens is, so it's the only way it'll work is if you work as a team. So when the team goes, when team hears about a preterm baby, so there is a clear job allocation, who does what. So there is in-house team and a team who goes for resuscitation. Team who goes for resuscitation does the delivery room care. But at the same time, what they do is they prepare a trolley for lines. They get all the things they don't, because you don't want to waste everything. So, but you also know some babies, like 22, 23, 24, 25, 26 weeks, we are going to do lines as long as they come back to the unit. And
this practice, Dr. Lamia.
so the nursing team prepare already
No.
the ventilator.
Yes.
They prepare the incubator, they prepare lines, they also take all the PN and everything out. So essentially, when the doctors come into the unit and they are securing the lines, there is 2 nurses already preparing the PN and all the drugs, antibiotics, vitamin, caffeine, everything is prepared. So when the doctor who scrubbed up and does the line, there is a nurse who's scrubbed up and prepares everything. And so as soon as the line goes in, they come to the other side, give everything to the doctor, and the doctor gives all the drugs, connects the PN, and that's done very seamlessly. So it's done very quickly.
Okay. But I think the premature baby who is sick and needs resuscitation, there is a lot of metabolic derangement in his body. So we need to stabilize all these, the blood gas analysis, the hypothermia, the hypoglycemia. Then we will start the nutrition. And this is not the priority in resuscitation.
Absolutely. So so the resuscitation never stops the other things. So the resuscitation is usually done by a completely different team in a different place.
I know.
So only after the baby is resuscitated, stabilized, then the team does the other things. And in some cases, the resuscitation and stabilization can go longer. And in that case, you can't do the 60 minute. And so that is the main thing. The priority is always baby, and in some babies you can't meet 60 minutes. So that is okay. So it's in every individual care is focused on that way. Yeah.
Thank you.
Professor Ahmed Shimran,
Introduction of early nutritional in the first few hours may lead to the special and sick baby. Especially premature may induce attacks of recurrent bronchiolitis. This is my practice. Be avoided to give fluid or nutritional after a few days from stabilize of his condition. Better to be postponed for a few days until his condition be stabilized, because there's a risk of recurrent collapse may lead to death of the patient. If we are starting early introduction of fluid or introduction of nutrition for those sick baby may lead to the more complicated. This is my opinion. What's your opinion about that? Thank you.
Notes that there is a lot of debate going on, like you say, particularly is PN harmful when you start early in extremely premature, extremely sick babies. Term babies, it's straightforward. We don't start PN straight away. We usually put them on IV fluids like 10% dextrose or dextrose saline, and only when we know that the babies are going to be on prolonged period of ventilation and we might not be able to start feeds early, then there are certain babies like that, like particularly surgical babies, we start PN. Whereas premature babies, there's a lot of discussion about what is right, what is the right way of moving forward. And in the past, like you say, when I was a registrar many years ago, you can see I'm very old now, we did that. We started 10% dextrose and then after 24 hours, and in some units, even after 48 hours, we used to start PN. But that's changed. But I think now, unanimously across UK, I would say all the big units I've discussed with, that is gone. The fear of catabolic state, fear of ability to, or the risk of giving PN early on is almost not discussed anymore. We start PN because nutrition, these babies, even a day or two, because their demands are so high, if you don't provide the right nutrition, we believe it might be counterproductive for them. And so every unit I know in UK would start PN on day 0. So essentially as soon as we can. So our fluid regime starts with PN, which is once the lines are in, and it's the same across UK. Most big units will do the same. But you're right that there is a lot of discussion also going on. Is that the right way of doing it? Are we harming the baby? But that the practice is to start as soon as we can currently.
Thank you.
Please, Dr. Naveen, some opinion of some centers is to use preterm parenteral nutrition formula that exclude lipids, without lipids anymore, and the lipid postponed to the day 4 of life. What's your practice in your center?
We start PN and lipid straight away. So we start with, well, of course, the lipid regimen goes up over 3 days for us, but we start straight away. So essentially lipid and PN, when I say PN, it's with lipid. Very rarely I would stop lipid, and I do stop lipid when they are in significant septic child, when I'm really struggling, and I would stop lipid. But generally, I give lipid for most of my babies straight away.
In general, which countries now are leading in this golden hour? In general, which centers are the best in neonatal care according to your practice now, from what you read in the articles and from what conferences you attend?
So I think so the big centers in UK and big centers in Europe, and particularly Western Europe, they are very good in golden hour. In fact, we are significantly late to the party. So I used to train in Yorkshire. Yorkshire is another region within UK. That's where I trained, and I did my research as a research fellow many years ago in Manchester area. So that's another big area. So we practiced golden hour even 15 years ago already, and they were very good at it. Yorkshire were probably the early adopters, and they did extremely well. I think they picked it up in 2010 already, and when Golden Hour was still at sibling stage, at baby stage, they picked it up, and they've got better and better at it. And I've been amazed by how good they are. But every other unit, big units, have been gradually adopting it. So most units now in UK, big units, tertiary neonatal units, practice that quite well. And when you go to the conferences, when you listen to some big European units, are very good at practicing that. And
Last
clearly there
question.
is recognition.
Dr. Athirman, we always ask about our colleagues, Iraqi colleagues in the UK. What is the impression? Have you met Iraqi colleagues in the field of pediatrics and neonatology? What's the impression about Iraqi doctors' practice in the United Kingdom?
So there are not many Iraqi doctors in the United Kingdom. I have one of my best friends, well, actually my wife's best friend, are from Iraq. So their parents are from Iraq. So they had migrated to move to Germany, and both they are twins, and the twins are my wife's classmates, and one of the twin is very, very, very close friend, and we still visit. And so I've got very good opinion about, and actually she talks a lot about, she still visits Iraq and talks a lot about places to visit. So there is plans to visit when we have time, of course. Time is the main problem. But doctors in UK from Iraq, there are not many, but I have Bara is one of them. I've worked with few doctors, and in Manchester when I was a research fellow, there was my consultant who's a consultant neonatologist who had come from Iraq. And my first proper job in UK in 2002. I worked with a surgical colleague who was my housemate as well. He had come. His first job was the same. He had come from Iraq, so we spent a lot of time exploring UK, northern part of UK together. So, and he's still a friend. But he's a surgeon, not a pediatrician. And yeah, so I've only worked with two doctors. One is my consultant in Manchester, and one is Bara, and all three, in fact, are brilliant at what they do. And
thank you very much, Doctor.
Overall,
Thank
I
you
think
for your time.
there's good reputation for overseas doctors in UK anyway.
At the end of this webinar, Doctor, thank you for your time. I know you work early at 6 a.m. Because there are 3 time zones difference between us. Thank you very much for sharing all this information, and we will hope for another webinar in the coming future. And send my regards to Dr. Professor Embleton too, and Bara.
Will do. We'll pass on the wishes, and thanks very much for inviting me, and all the best for everything. And hope everything goes well. We'll hopefully see you in Iraq, and because Babylon is, since Boney M has sung that song, Babylon is one of my favorite cities. So I hope to visit at some point and catch up in person in the future.
Be sure that you will be a welcome guest here.
Take care. Thanks very much for that.